I'm here.
Okay.
Okay, so we are already live. Greetings to everyone. This is Ruksha from Team CLIRNET as a session assistant for this particular session. It is with great pleasure I welcome one and all to this session. Allow me a moment to share significant highlights of CLIRNET. CLIRNET is the leading healthcare platform and thrilled to announce its momentous milestone in its mission to empower healthcare professionals worldwide to improve patient outcome, and that has established CLIRNET as a premier hub for knowledge dissemination and professional collaboration. For more information and to be a part of this innovative initiative, download CLIRNET app and avail all of the above features. Thank you for your patience. So before we begin, I would like to introduce today's theme, Approach to Knee Pain. We have five distinguished speakers who will each elaborate on various subtopics related to our today's theme. So it is my distinct honor and privilege to introduce our first esteemed speaker of today, a leading expert in the field of orthopedics and spine surgery, Dr. Chinmayanath sir, who holds an MBBS and MS in orthopedics and has further distinguished himself with an MRCS from Edinburgh. His extensive training includes a clinical spine fellowship at the National University Hospital in Singapore, as well as prestigious spine fellowships with the ISSLS in Munich. Currently serving as a consultant orthopedics and spine surgeon at Apollo Multispeciality Hospital in Kolkata, and associate professor in the Department of Orthopedics at JIS School of Medical Science and Research in Howrah, West Bengal. Last but not the least, he is the honorary secretary of the WOC India chapter, the joint secretary of Spine Society of West Bengal, and an executive committee member of the West Bengal Orthopedic Association. So, without any further ado, I would like to welcome you, sir, for sharing your valuable insights on symptomology in the knee, identifying the problem. So please proceed with your talk.
Thank you, Ruksha, for the nice introduction. Good evening, everybody. Uh, Dr. Arinda Banerjee, one of the pioneer of SICOT and current president of WOC International, and also many distinguished educational post holder of SICOT International. Dr. Shashinder, he is also a personality in education. He's been he's a professor orthopedics in medical college in Pondicherry, Dr. Samandeshwari, and Dr. Shekhetra Madanda, though he does not join. So today we are going to discuss the knee pain. And my topic of discussion is symptomatology of the knee, identifying the problem. So knee is the largest joint of human body, and there are various problems may happen in different directions from the knee. It's actually a 360-degree problem orientation. And if we think how many patients come to the medical facilities with a knee problem, it is approximately 5% of all primary care visits. 25% of adults suffer from knee pain in any time of their life. The prevalence of knee pain has increased almost 65% over the last 20 years because the life expectancy has been significantly increased in last 2-3 decades of life. And also the pace of life has increased all over the world. The common symptom affecting both children and adults actually, and for all age groups. So the assessment of all the problems of the knee is important, especially the pain, which is our discussion today. Now, why we have to assess and evaluate? Because initial evaluation should emphasize excluding the urgent care which need for referral. And standardized comprehensive history and physical examination differentiates the diagnosis and helps in going to the right path to do or to start the best management for the patient. Now, symptoms of knee pathology. The pain, which is the symptom we are discussing today. The pain when squatting on when climbing stairs at knee. Pain while running or jogging. Pain in the front of the knee after sitting with the legs bent for long periods of time. Popping or cracking sounds when bending the knee. Stiffness, especially when the patient first wakes up. Swelling in front of the knee or back of the knee, bruising around the knee giving out sensation or buckling under pressure or instability or locking. These are all the associated symptoms along with the knee pain. So the knee pain, if we think it in the location wise, broadly it is anterior knee pain or tibiofemoral pain. The anterior knee pain is the site of the pain may be patella or the quadriceps tendon or patellar tendon. So isolated anterior knee pain may be patella, patellar tendon, and patellofemoral pain syndrome is one of the important things. And the tibiofemoral pain may be subdivided into acute or chronic. So the anterior knee pain, which we have started discussing, may be distinct or may be obscure, in which the exact pathology may not be easily found. The distinct things are overuse syndrome, trauma-related lesions. Many, I'm coming to the details of this. There are many trauma in different structures of the knee, dysplasia, tumor, and arthrogenic pathology. Obscure anterior knee pains are patellar maltracking, chondromalacia, idiopathic pain, reflex sympathetic dystrophy, and psychogenic pain. Now, tibiofemoral pain may be acute, which I have already discussed. There may be recent injury to the bone, to the menisci, to the ligaments, and other structures. Or chronic, causing arthritic change, maybe osteoarthritis, maybe rheumatoid arthritis, or really juvenile rheumatoid arthritis or crystal arthropathy like gout or pseudo-gout, CPPD deposition disorder. Now, common causes of knee pain by age group. If we divide in children and adolescents, the common causes are patellar subluxation, tibial apophysitis, or that is commonly called Osgood-Schlatter disease, jumper's knee, like patellar tendonitis, and osteochondritis dissecans. In adults, the patellofemoral pain syndrome, chondromalacia patelli, which is a very obscure symptom, the medial plica syndrome, pes anserinus bursitis, ligament injury to the ACL, PCL, MCL, LCL, etc., posterior corner injury, etc. Meniscal tear, maybe medial meniscus commonly or lateral meniscus, and sometimes inflammatory arthropathy causing the pain while after the race, and septic arthritis. And in elderly, the common pain symptoms, pain arises from commonly due to osteoarthritis, crystal-induced arthropathy, popliteal cyst, etc., or Baker cyst, etc. So if we think knee pain arises from which sides, anatomical sides, maybe anterior knee pain, I've already discussed, medial knee pain, lateral knee pain, and posterior knee pain. So it is 360 degrees. So if we think about the anatomy of the knee, anteriorly there is patella. You all know that. I think we don't need to elaborate it. There is quadriceps tendon attached with the patella, upper superior border of the patella, then patellar tendon, which continued from the patella to the patella to the tibial tuberosity. Medially, there is medial collateral ligament. Laterally, there is lateral collateral ligament. Anteriorly, and inside the knee, there is anterior cruciate ligament from the anterior, just near the anterior end of the medial meniscus, and going towards the lateral condyle of the femur. And there is PCL, posterior cruciate ligament. There are different functions of these ligaments. And then articular cartilage covering the femoral side, tibial side, and the undersurface of the patella. So these are the anatomy of the knee joint. And in the right hand side picture, the ligaments ACL and PCL is quite clearly depicted. Now, if we think about the disease map of the knee, this is the anatomy of the knee, the tendon of the different tendons of the knee. And on these, if we think, then from where it is these pains are arising, So there are 6 different zones. A, that is above the patella, and at that area, quadriceps tendinitis and quadriceps tendon rupture are the common patella. And B, that is lateral part, lateral side of the patella, lateral retinaculum. Here, the common pathology are ITB syndrome, lateral meniscus tear, LCL injury, dislocated patella. Then C, that is just over the patella. Here, patellofemoral pain syndrome, chondromalacia patelli, arthritis, housemaid's knee, bipartite patella are the common pathology which may cause pain. D, that is medial side of the patella, or the medial side of the patella, medial side of the knee joint, MCL sprain, medial meniscus tear, and arthritic pain pops up here. E, that is inferomedial corner. Here, medial plica syndrome and pes anserinus are the common causes of the pain. And F, that is the last zone, that is inferior to patella. The patella tendonitis, Osgood-Schlatter disease, osteochondritis dissecans, SLJ disease, and infrapatellar bursitis. These are the common pathology which may cause pain in this area F. Now, anterior knee pain, patellar subluxation or dislocation, tibial apophysitis, jumper's knee, and patellofemoral pain syndrome. Medial knee pain, medial collateral ligament pain, medial meniscus tear, pes anserinus bursitis, and medial plica syndrome. I'm reiterating the symptoms. Lateral side, these are the symptoms, ITB pain, etc. And posterior side, it is popliteal cyst, Baker cyst, which is not depicted in that picture, and posterior cruciate ligament injury. So, while keeping in mind those pathologies and the area where those pathologies can cause pain in the knee joint, we should start our clinical assessment from history taking. Should do history taking very thoroughly. Otherwise, we will be beating around the bushes and doing a lot of unnecessary investigations. So get the history very clearly. Then do the proper clinical examination. And then on top of this history and clinical examination, and based on these things, we suggest the investigations and then reach the diagnosis. Now, history of knee pain should start from age of the patient, location of the pain, onset of the symptoms, character of the pain, duration of the symptoms, or any precipitating trauma. It is very important. Whether there is a sports injury, whether there is a bike accident, whether there is a fall from height, etc. Now, mechanicals, whether the symptoms are mechanical or not, whether the symptoms are inflammatory or not. Inflammatory symptoms starts at the early of the morning or after the rest. Mechanical syndrome symptoms arise when there is a lot of excursion of the joint. Systemic symptoms for infection, tuberculosis, etc., very important, or rheumatoid arthritis. History of swelling, whether it is present or not. Previous medical and surgical procedures. Okay. Then, after the history taking, we should start the clinical examination of the knee, which is very common. It starts with the stiff complaints, then history of present illness, then important negative history, very important. And I'm coming to the point. Past history, family history, personal history, and treatment history. Whether there is any surgery, whether there is any physiotherapy, whether there is any other sort of medical treatment or interventional treatment on it. Chief complaints, the most common complaints for which we are here, there is pain. And along with that, there may be swelling in the knee joint. There may be giving way or sensation or instability. There may be a locking sensation. There may be deformity of the knee. And we have to think of the ideal because most of the patients are young or middle-aged. They are active in their life. So whether they are able to walk, whether they are able to run, whether they can sit cross-legged or stoop or squat or not, whether they can ride bicycle or whether they can drive one. An important negative history may be multiple joint pain, which guides us towards the rheumatoid arthritis or the inflammatory arthritis sort of thing. Constitutional symptoms like fever, weight loss, then loss of appetite, etc. Then it guides us towards tuberculosis in our country, or maybe septic arthritis if the symptoms are very acute and severe. The pain at grade 2 may lead us towards gout. Gout may affect the knee joint. Well, history of trauma, fever, bleeding diathesis, very important because there is many conditions like hemophilia, knee joints are affected. The history of exposure, sexual exposure, which may cause Rita's disease or gonorrhea, which may cause internal arthritis. Now, we have to look the knee joint or do inspection. First, when the patient comes to your clinic or the hospital, then we have to look first the gait. How the gait is. Is it antalgic? It is not knee gait. It is cross-legged gait or not. Now, attitude in supine position or standing position. Whether the
Kimber, can you
knee is
speak a little loudly? Sometimes we can't hear very well. Speak a little loudly.
okay. So the attitude of the patient may be supine, may be standing. Now it's clear. Is it clear? Hello.
Yes, sir, it is
Yes, it
clear.
is clear.
Yeah.
Yeah.
Now attitude of the patient may be supine, may be standing. The level of anterior superior iliac spine is very important, whether the limb is shortened or not. The level of patella is more important, whether it is above the normal side or the lower level than the normal side. Position of the hip, whether there is fixed flexion deformity in the hip or not, whether fixed adduction deformity or not, the position of the knee, position of the ankle. Deformity, maybe fixed flexion deformity in the knee, maybe valgus or varus deformity. Maybe swelling accompanied with the pain. And if there is swelling, size of the swelling, shape, surface, and extent. And we have to look up the fullness of the suprapatellar pouch or suprapatellar fossa and parapatellar fossa, both in the supine position as well as in the standing position. And we have to look for any scar or sinus around them, maybe front, maybe sides, maybe back. And posteriorly, we have to look at making the patient prone to the color of the skin, whether there is scar, sinus, etc. or not, whether there is any lymph nodes or not, or popliteal slope, how is the and popliteal fossa, whether there is any swelling, whether there is any cyst, whether there is any redness or etc. Now fill. We have to look the temperature of the knee first by back of our hand. Then tenderness, both superficial and deep tenderness, maybe in the joint, all the joint lines, medial and lateral joint lines, patellofemoral tenderness. I'm not going into details of that. How to elicit the patellofemoral tenderness. The structures around the knee, we have to fill and test the medial collateral ligament, lateral collateral ligament, all the bursa around the knee, and we have to look for the synovial thickening. Then bony components like femur, tibia, and patella, we have to palpate. Then joint line tenderness, we have to elicit in the both medially, laterally, and underneath the patella, I've already told. Then we have to do fluctuation. We have to test the fluctuation by patella tap or cross fluctuation test around the knee. I'm coming into that. Now effusion. If there is mild effusion, then we have to inspect the patient at the standing position. Then there is a fullness of the infrapatellar fossa. If there is moderate effusion, we have to check the cross fluctuation or patellar tap. And in severe effusion, patellar tap may be positive, and if it is very tense, even the patellar tap may not be positive, but the patella is floating. Now, how to elicit patellar tap? This is the technique. You have to put your left hand or non-dominant hand just over the suprapatellar pouch and push the suprapatellar pouch towards the knee joint, fluid of the suprapatellar pouch towards the knee joint, and then you have to follow the left hand side picture with your index finger of the right hand or dominant hand. You have to tap the patella back to the articular surface of the lower articular surface of the femur. Now, whether there is any fluid or not, we can test by a fluctuation test. Patient's position is supine, examiner's position adjacent to the test knee, and the examiner places the palm of a hand suprapatellar, the suprapatellar pouch, and the palm of the other hand anterior to the joint line with the thumb and index finger just beyond the patella, pressing down with one hand, and then with the other hand we can feel, just like fluctuation in the abdomen. You can feel cross fluctuation test inside the patella if there is moderate amount of fluid. The indications for a positive test: increased fluctuation of the fluid, of the knee compared to the contralateral side indicates there is significant diffusion. Now movements. The normal flexion movements is 0 to 135 or 130, 145 degree. 135 degree usually for the male, slightly less in male and slightly more in females. And you should look for any quadriceps leg. Now measurements. Linear measurement may be true length of the limb. We all know how to do how to test the true length, how to measure the true length. Then apparent length, if there is any apparent shortening or lengthening, or true shortening or lengthening, and segmental measurement of the thigh and of the leg below knee. And then circumferential measurement for wasting of the thigh and calf. And the deformity assessment may be done with the Q angle, 14 to 16 degree for the female. This is the picture for the Q, measuring the Q angle. The intermalleolar distance for genu valgum, less than 5 centimeter. Intercondylar distance for the genu verum, 0.5 to 1 centimeter is the normal. Then torsion of the tibia to be measured, checked by rotational profile, and femoral anteversion should be checked. Now, coming to the special tests, very important for the ligament injuries. Latchman test, anterior Dwyer test, posterior Dwyer test, valgus varus stress test, McMurray's test, Apley's grinding test, Apley's distractor test, and pivot, very important, pivot shift test and Slocum. So this is the Latchman test. Stabilize the femur with one hand, we all know, and the tibia with the other hand, and pull the lowering the femur anteriorly and push the distal tibia. So this is the push the lowering the femur and pull the proximal tibia anteriorly. This is the Latchman test. Latchman test is positive, usually in the acute, maybe in the acute, can be done maybe in the acute setting as well. But the Dwyer test is also for maybe for anterior cruciate ligament and for posterior cruciate ligament. But anterior Dwyer is for anterior cruciate ligament. It can be done only in the chronic setting, not in the immediately after acute injury. It's very painful. So the right hand side picture shows how to do this anterior Dwyer test. Leg and thigh should be at 90 degree angle, and you have to fix the foot and pull the proximal tibia anteriorly by putting your thumbs just by the two sides of the tibial patellar tendon. This is the posterior Dwyer test. It is positive in case of posterior cruciate ligament injury. This is the valgus and varus stress test. Both should be done at 30 degree of the flexion position. And it's valgus stress test is positive if there is opening up of the medial joint line, and valgus stress test is positive in case of MCL injury. Similarly, varus stress test is at 30 degree. It is flexion of the knee, and there is opening up of the lateral joint line, maybe some pain, and it is positive in lateral collateral ligament. McMurray's test. It tests the integrity of the lateral or medial meniscus. This is the method. And Apley's grinding and distraction test. Previously, much importance were given onto this, but nowadays it is almost discarded because of confounding factors and other. It is sensitivity and specificity. The specificity is very poor compared to other specific tests. Pivot shift test, very important. It is a gold standard for test for ACL injury. The leg is externally rotated, valgus force is applied on the legs, and as the leg is flexed, a positive test is indicated by clunk sensation. Now, finally, the Slocum test. Patient is on the sideline position. The bottom leg is on the uninvolved leg, and the knee of the uninvolved leg is flexed to add stability. The foot of the involved leg is rests and is stabilized on the examining table with the patient's foot, and the examiner applies valgus stress to the knee while flexing the knee. The positive test is subluxation of the knee to reduces at the between 25 or 30 to 45 degree of the flexion. So the take-home message from this examination of the knee is there are diverse symptoms arises from the knee pathology. And the knee pathology is so diverse that it can occur 360 degree around the knee. So before doing any clinical assessment, thorough knowledge of the anatomy is of paramount importance, and there is no substitute for thorough clinical examination as well as relevant clinical tests. Thank you very much for your patiently listening.
So thank you so much, sir, for this wonderful discussion. And so we have received two questions from our delegate doctors, and I have posted those questions in the Zoom chat box, so you can check once.
Please ask the question, Dr. Chinna, the presentation. How does the assessment of the knee symptoms differ in the special populations, such as athletes, elderly patients, and individuals with systemic diseases? So assessment of the knee symptoms in special populations like athletes, we have to give give more emphasis on the injuries while running or while doing sports activities, and we have to give more importance towards the injury of the ligaments and cartilage in case of athletes, because they are more prone to this ligament injury and cartilage injury. So we have to have more sensitivity over this. And in case of elderly patients, there may be occult fracture, which may not be diagnosed with X-rays, and also clinical examination may be very difficult sometimes in very painful knee. All the clinical examination, special tests may not be possible. So we have to rely a bit more on the investigations. And individual with systemic diseases, we have to consider whether there is any allied systemic symptoms or not, which is related with the knee pathology. Maybe in our country, very common is the tuberculosis of the knee. The patient may present with a chest pain, with hemoptysis, etc., and may be diagnosed with pulmonary tuberculosis. And sometimes after that, after or during the treatment, the patient may develop knee swelling, sudden onset of knee swelling, or gradual onset of knee swelling with stiffness or without stiffness. Then we have to give our importance and towards the knee, and we should think that there may be an inflammatory arthritis as well as maybe the tuberculous affection of the knee joint.
Thank you so much, sir. So there's another question. Sir, should I read it out?
Yeah, please.
Okay, so the question is chronic osteoarthritis, pain not subsiding even after taking routine medicines after 1 month, difficulty in weight bearing. What to do, sir?
If there is the patient is having, it's not the purview of this lecture, because it is my lecture is discussing on the symptoms and approach to the meeting. So
I think
if
at the end of the presentation, if it is not clear, then we will take it again.
Yeah, it is.
My lecture will cover many of these topics, so we can discuss it
Okay,
later
sir.
at the end of it. Okay.
Okay, sir. Thank you so much, sir, for this.
Thank you very much. I'm leaving because I have to join another meeting.
Not an issue, sir.
Thank you, Dr.
Thank you so much, sir, for being a part of this session.
Thanks. Bye.
Bye, sir. So, can we move on to our next lecture, sir?
Yes, please. Yes, please.
Okay, sir. So now moving forward to our next talk, I would like to introduce our second speaker, Dr. Sasinder Sundaram, sir, who is an esteemed specialist in shoulder and knee arthroscopy surgery with a distinguished career marked by numerous qualifications and fellowships. He holds an MS and DNB in orthopedics. He's also a fellow of ISOC and FASM and a cartilage reconstruction fellow from UK. Currently associated as the professor of orthopedics at SLIMS, Pondicherry, India. He serves as the Vice President of World Orthopedic Concern, India, and is the editor of WOC International. He's also the chairperson of the Education Committee and the member of Arthroscopy Committee, SICOT. Today, sir will be discussing the role of arthroscopy in the management of conditions of the knee. So, sir, please proceed with your talk, sir. The stage is all yours.
Yeah, thank you very much, Ruksa. Let me share my screen.
Sure, sir. It is perfectly visible, sir.
Yeah, thank you. Thank you very much. First of all, I would like to thank CLIRNET and our president of the World Orthopedic Concern for this wonderful opportunity. I will be talking about arthroscopy in the management of conditions of the knee. So thanks to CLIRNET, and I would like to say a few words about World Orthopedic Concern, that is WOC. World Orthopedic Concern is an international society that collaborates with multiple societies and countries with the aim of networking, patient and doctor education, and medical outreach, as in orthopedic surgeries in peripheral parts of the world and also the country. So we have the international body, that is World Orthopedic Concern, and also the Indian chapter of World Orthopedic Concern. So this webinar is done as part of the Indian chapter of the World Orthopedic Concern. If anyone is interested to know more or to join the society, I would like you to contact me in the following email at the bottom of the slide. I am Dr. Sasinda, Professor of Orthopedics from Lakshmi Narayana Institute of Medical Sciences, Puducherry, India. I'm a shoulder and knee arthroscopy society. So going on to the presentation, I will touch upon a bit on the anatomy of the knee joint and then go on to the arthroscopy. So we know about the anatomy of the knee joint. We have a knee joint as a complex joint. We have the femur above, the tibia below, along with the fibula. We have the articular surface. There are a lot of ligaments. Some ligaments are extra articular. That is the collateral ligaments, medial collateral ligament or MCL, lateral collateral ligament or the LCL. Then you have intra-articular ligament, that is ACL, PCL, and also the menisci. Menisci or the shock absorbers. We have the medial meniscus medially and the lateral meniscus laterally. So the ACL starts from anteromedially in the tibia and runs posterolaterally to attach in the lateral part of the femur, from anteriorly in the tibia to posteriorly in the femur. The PCL runs from posteriorly in the proximal tibia, goes above anteriorly to the lateral femoral condyle. Sorry, medial femoral condyle. Okay, and the meniscus, you have the medial meniscus and the lateral meniscus. Both of them anteriorly, they are connected by the intermeniscal ligament. Posterior to the menisci, we have the posterior cruciate ligament. Anteriorly, in between the two menisci, we have the anterior cruciate ligament. The medial meniscus is larger. The lateral meniscus is smaller and more rounded. As far as the microstructure of the meniscus is concerned, we have longitudinal fibers and also the horizontal fibers or radial fibers. So this is very important to understand because the meniscal tears will depend on which fibers are torn, and also it is important to understand the vascularity of the meniscus. Peripherally, the meniscus is well vascularized. The central part is not so well vascularized. The innermost part is avascular. So this decides the treatment of the meniscus. So going on, just to understand the mechanism of injury, the most common injury that happens in the knee joint is ACL tear along with meniscus tear. And most commonly it happens from landing in a wrong position and internal rotation of the knee joint. So basically it just twists. And it is not essential that you have to be an athlete in order to tear your meniscus. Even just a script when walking, what decides is the position of the knee, the amount of force that happens on the knee, not on the whole body. This is what that decides whether the meniscus is going to tear, the ligament is going to tear, which ligament is going to tear, whether the ACL or the PCL or the collateral ligaments. Previously, the treatment were open, as in open surgery was performed in order to treat the anterior cruciate ligament or the meniscus or the posterior cruciate ligament. It can be more cumbersome or it can lead to more complications for the patient. But things have improved a lot. Nowadays, we have arthroscopy for the treatment of majority of the conditions of the knee. I'm not going into the details of the diagnostic. So for knee condition, Dr. Chinmay has covered and the investigations that are required. I will go straight into the arthroscopic modality of treatment and what conditions can be treated by arthroscopy in the knee. So these are indications for arthroscopy, but the first one is almost not being done at all because the investigative methods like MRI have improved so much that the diagnosis is already possible. So nowadays, almost never we take up a patient for diagnostic arthroscopy of the knee, but all the others, including partial meniscectomy, meniscal repair, anterior cruciate ligament ACL reconstruction, PCL reconstruction, cartilage repair, removal of loose bodies, etc., are being performed and can improve the condition of the patient a lot. So going on to arthroscopy as a treatment for conditions of the knee. Before any surgical procedure, you have to be very clear in your diagnosis. Make sure you have assessed the knee joint very well even before you operate the patient, because MRI can be deceptive. Do not operate on a patient based on MRI. As far as investigation is concerned, MRI is the gold standard investigation for conditions inside the knee joint. For example, here to demonstrate the ACL tear, this is the anterior cruciate ligament. As I said, it starts from anteriorly in the tibia to posteriorly in the femur. That's the ACL. This is the PCL. The menisci are not seen here because this is a mid-sagittal section MRI. The menisci will be visible on the medial sagittal section or the lateral sagittal section. There's a mid-sagittal section through the femoral notch, so the menisci are not visible here. And this is an example of how an ACL tear looks like. Here, there is a clear structure attached anteriorly in the tibia and the posteriorly in the femur, but here that is not visible. So this is the ACL tear. So what do you do? Once you decide, not all patients of an ACL tear with ACL tear needs surgery, but most of the patients with a complete ACL tear will require surgery. So once you decide that the surgery is required, then there are multiple things that you have to decide. As far as the surgery planning is concerned, you have to decide whether you want to do a reconstruction or you want to do a repair. There is a lot of difference between these. Reconstruction means you are replacing the pre-existing tissue and putting a new tissue that will form the new ACL. Repair means you are just reattaching the tissue over there in order to allow it to heal. Previously, ACL repair was almost non-existent, but it has developed a lot nowadays. But because it is a relatively new technique, I'm not going to talk about ACL repair. I will talk only about ACL reconstruction. With respect to reconstruction, we have to decide what graft. In other words, I said that we have to replace the ACL with a new tissue. So that is called a graft. So we have to decide what graft has to be used. Most commonly used is the hamstring graft, that's semitendinosus and gracilis insertion, tendinous part at the insertion. But there are other options also, that the patellar tendon, Achilles tendon, especially from cadaver, or autograft. You can have quadriceps tendon, peroneus longus tendon, etc. I'll discuss more about it. And then you have many methods of fixation. There's something called aperture fixation, or in other words, it's a screw fixation of the ACL above and below. You have bioabsorbable screws and you have metal screws. And there's something called suspensory fixation, as in you use a button on the femoral side and the tibial side in order to suspend the graft from the bone ends. Or you can have a hybrid fixation, that is a button on one side and a screw on other side, just for technical reasons. This example of how an arthroscopy looks, you have to decide whether you want to preserve what is normal. For example, in this video, if you see, anteromedial bundle is torn, posterolateral bundle is attached to the PCL. If you decide, you can even decide to preserve the partially attached posterolateral bundle in order to maintain its vascularity and the neurovascular structures. So this is an example of a bundle preserving or remnant preserving ACL reconstruction, wherein the remnant part is visible here and the new reconstructed part is here. So it will vascularize faster and heal faster. After the patient is under anesthesia, you examine the patient once again. You have to make sure whether your diagnosis is correct, and you also ensure whether there is a pivot shift positivity. That means more ligaments are torn or the knee is more unstable. Then you proceed on to the arthroscopy. This is an example of how an ACL tear looks like. The stump of the ACL is completely torn from its attachment in the femur, and this is a big stump. When it is completely torn, usually you resect it, you remove it, and then you start reconstructing it by putting a new graft inside. Also look for possibility of meniscus tears, especially in the posterior horn. See, this is a beautiful example of a hidden meniscus tear. In the posterior horn, medial meniscus, if you see underneath, there is a tear. I'm probing it and there is a tear. There is a high chance that you will miss it. That has to be identified. Then you go on to harvesting the graft. This is the gracilis graft. This is the proximal tibia medially. Patellar tendon here. This is the medial aspect. Gracilis, semitendinosus, and sartorius. And then more medial to it, you have the superficial MCL. Don't damage the superficial MCL. Have the gracilis and semitendinosus with small incisions. And then prepare the graft. The graft is prepared to make it at least 8 millimeter thick and sufficiently long, depending on what type of ACL reconstruction you're doing. Usually, minimum of 70 millimeter or 80 millimeter is required in order to do an ACL reconstruction. This particular graft is a bit shorter because it's an all inside ACL reconstruction, which is a special type of ACL reconstruction. So this is how a graft is prepared. You can also harvest the patellar tendon, especially when it is athletes. You harvest the mid part of the patellar tendon without damaging the peripheral, both the medial and lateral parts of the tendon. Or you can harvest the peroneal tendon, especially when you have multiple ligament injuries. You have the MCL tear, LCL tear, ACL tear. You need more grafts to reconstruct. Then you can harvest the peroneus longus tendon also. Or you can also harvest the mid portion of the quadriceps tendon. Quadriceps tendon is found primarily by the vastus intermedius and vastus medialis lateralis joining together, and rectus femoris. You take the superficial part of the quadriceps tendon or the full thickness part in the central region of the quadriceps tendon in order to reconstruct the ACL. If you have a meniscus tear, you have to repair the meniscus tear. You can repair by multiple methods. An all inside technique wherein a special instrument is used in order to clip together the torn portions of the meniscus. Or you can do it by an outside in technique, where you use spinal needle and wires and switch the wires and switch materials in order to repair the meniscus. And then you make the tunnels in the femoral side and the tibial side for the ACL reconstruction, and you pass the graft into the joint. And that is that's the button on the femoral side. I'm going to use a button on the tibial side also. That is the graft that is going in, and that will form your ACL reconstruction. The graft will heal into the new ACL. Okay, but don't forget, just because you have finding of ACL tear, don't forget to examine the collateral ligaments. There can be valgus opening. That means MCL is torn. Then, if it is an acute situation, you have to repair the MCL, medial collateral ligament, with anchors proximally and distally. Or if it is a chronic situation, you have to reconstruct. That means replace the MCL with a new graft. If you don't do it, then your ACL is also going to fail. In addition, you have to make sure you're not missing some cartilage injury. This a full thickness cartilage loss. You autograft. You do a cartilage transplantation in order to resurface the cartilage. So that damaged portion of the cartilage is removed as a cylinder, and then that has been autografted from cartilage taken from the anterior portion of the knee, and it has been resurfaced. It will heal very well, and the patient's pain will improve a lot. If you do only an ACL reconstruction, the patient is not going to be completely all right. There's another situation. There's a cartilage, full thickness cartilage loss that has been reconstructed with cartilage. This can be a situation in the patella also. You remove the affected part and you reconstruct it with for new cartilage. All said, Don't forget deformity. If you have a deformity in the joint, just doing an ACL reconstruction is not going to be helpful for the patient. The patient is going to have persistent pain, and the ACL is also going to fail. This patient with ACL tear and also deformity. If you see, the left knee is in varus, but the right knee is in varus. This intraoperatively, the right knee is in varus. The patient is undergoing a high tibial osteotomy along with ACL reconstruction. I do single stage ACL reconstruction along with high tibial osteotomy. High tibial osteotomy means you are doing a cut in the bone and correcting the deformity into varus. You are creating mild varus depending on how much of varus is present preoperatively. That is assessed based on scanogram, standing X-ray scanogram. So finally, you have a correction of the varus deformity and you have an ACL reconstruction. You have a button here and a button here, and the deformity is corrected, the ligament is corrected, and the patient will recover well. Is arthroscopy without any complications? No, any procedure can have complications. For example, it can be simple complications like ecchymosis because you're going to drill the bone in order to create a tunnel. So there can be some bleeding, that is totally fine. But there can be infection also. The risk of infection is 1 to 2%, but it is still important to make sure you're not missing this, and precaution or prophylaxis is far better and a must to avoid infection rather than to worry later. There can also be risk of effusion and stiffness after surgery, especially when surgery is not done with adequate precautions, as in debris is not cleaned properly, you inadvertently damage cartilage, or even for no reason when the patient has a tendency for stiffness, that is a possibility. You have to explain the patient. So finally, to take home, arthroscopy is a wonderful treatment method when it is a wonderful treatment method. It is very efficient in managing the patient. However, the learning curve can be high in order to learn the triangulation of arthroscopy and the procedures. However, the surgery also has to be done for the right indication. The right procedure has to be done by experienced surgeons. All the more important is rehabilitation after surgery and following up after the surgery. So when all these are done very well, the patient can and will improve very well after the surgery. Thank you. If you have any clarifications or about WOC or regarding the talk, you are free to contact me by email, and we will also have a discussion session at the end of the program. Thank you.
Sasinder, two quick questions.
Yes.
The first question is, at what stage after acute trauma would you consider doing a ACL reconstruction? That's number
Yes.
one. And number two, we had this concept that 1/3 patients require ACL surgery, 1/3 maybe, and 1/3 definitely don't need it. So is that valid nowadays?
Yeah, thank you, sir. So regarding the first question, how acute is okay? How early you can do the surgery? There are two schools of thoughts. Some people say that one school of thought is you should not operate the patient immediately. The other school of thought is you can operate the patient immediately. Even some people even consider that MRI should not be done immediately after injury because it will be difficult to identify the problem. But I do not agree to these. MRI can be done immediately after the injury because the hemarthrosis itself will act as a contrast in order to identify the ligament problem. So MRI is not contraindicated, and as far as the injury is a single ligament injury, for example, isolated ACL tear or along with a meniscus tear, there is no specific contraindication for early surgery. Contraindication for early surgery happens only when there is multi-ligament knee injury or the capsule is torn. The joint cannot maintain fluid. The fluid will leak into the posterior surface areas, and there can be a possibility of compartment syndrome. And multiple ligament injury is when you immobilize the knee, the smaller ligaments or the extra-articular ligaments can heal a bit by themselves. So you will have less structures to reconstruct or repair rather than having to repair everything. So a multi-ligament knee injury is a scenario where you should not operate immediately. There is no contraindication for operating immediately for an acute ACL tear. And the second question, yeah. In other words, maybe with respect to your question, the 1/3 needs an operation, 1/3 maybe, and 1/3 does not need an operation. There is another way of understanding it. There used to be a concept of copers and non-copers. Copers mean a patient has an ACL tear, but he is coping up with it. He is not able to. He is not specifically mentioning a complex instability. And non-copers is those who mention instability. I will make it very clear, more than the MRI or the clinical assessment, what is most important is the history. The question is whether you have an instability. If you have an instability, the most likely treatment that the patient will require is a surgery, arthroscopic ACL reconstruction. The concept of rehabilitation still exists, but how long will you have to keep rehabilitating the patient? As long as the patient is alive, the patient has to take care of his rehabilitation, or he has to compensate the absent ACL by the other structure, that is the quadriceps hamstring, etc. Usually it is not a scenario. Compliance is a big problem. And long-term outcome studies have shown clearly that arthritis is a problem if ACL is not reconstructed. So unless if the patient is not complaining of instability, absolutely no for surgery. But if the patient is complaining of instability, I do advise prehabilitation, but that does not stop me from proceeding with the surgery. Prehabilitation is only to prime the patient, prepare the patient, but not as a alternate for surgery.
That's
So thank you so much, sir, for
Thank
this
you very much.
elaborative discussion. So can we move on to our third lecture?
yes. Please go ahead.
Okay. So our third eminent speaker of today's evening is Dr. Samundeshwari Sasinder ma'am. She is a specialist in shoulder and knee arthroscopy surgery with an impressive array of qualifications, including MS in orthopedics and MBA in hospital and health system management. She is a fellow at Academy of Surgical Medicine in both Oman and Singapore. Currently, she is an assistant professor of orthopedics at SLIMS Pondicherry, India, and also serves as a joint secretary of WOC India. Today, ma'am will be discussing on orthobiologics of knee pathology. So welcome, ma'am. Please carry on with your talk.
Thank you for the warm welcome. Is my screen audible? Sorry, is my screen visible?
Yes, ma'am, it is visible.
Am I audible?
Perfectly, ma'am.
Okay, thank you. Thank you for the warm welcome. Beforehand, I would like to thank Dr. Arindam sir for the opportunity. Today, the topic given to me to discuss is about orthobiologics, about the myths and the truths which is currently present, and I can discuss it with certain evidence-based articles. So, what are orthobiologics? These are substances which are naturally occurring from our body, which is being taken to enhance healing of the injured or diseased tissues. And it is taken from our own cell, and in the market it is available, or it is available taken from the cadaveric cells, that is the allogenic form. And most of them are acellular or cellular components. The various sources from which these substances taken include the blood, the bone marrow, the adipose tissue, the synovium, amniotic materials. And the products can be manipulatable to varying degrees for various diseases and pathologies. So, what are the myths which we commonly see in our practice, or the patients come and ask us? The orthobiologic treatments are experimental and not yet approved. This is the most common question which I get in my clinical practice. So what we have to understand here is there are various spectrum of orthobiologic treatments available, such as PRP, which is a biologic agent, and hyaluronic acid, which is a medical agent. And these injections are having little or good evidence currently. though there are other evolving treatment modalities such as mesenchymal stem cells, and adipose derived stem cells, gene therapies, and some more biological agents which are in uptrend, but these are under clinical trials yet. And there is extensive clinical evidence supporting all orthobiological treatment. Is it so? Actually, speaking, there are only fewer agents which have a good backing efficacy, whereas, as I mentioned, the others are requiring still a lot of clinical trials with the safety issues. So before you jump into conclusion and provide an orthobiological treatment for your patient, do check for current evidences. What are the recent evidences and what are the newer agents available in the market? Because there are a lot of people who walk into your clinic and say about the availability of various newer agents and try to sell it around you. So always go back and check for what is the current evidence and the status of the particular agent in the market. And there is a hype that these treatments are available for the athletic injuries, that it cures of everything, and so. But the truth is, these agents are used for injury recovery in athletes, but they are also used for treatment of other non-athletic injuries in degenerative diseases, inflammatory arthritis. They have a wide spectrum of role. So we see the common articles suggest the role of orthobiologics in the management of cartilage and meniscal injuries in the sports. So these are not only treatment of choice for sports injuries, but also for degenerative diseases such as osteoarthritis. And they have no role in the early stage of knee pathology. For example, if you see the knee osteoarthritis, we can intervene early and identify the patients of early osteoarthritis and give these orthobiological agents. These patients will have a better symptomatic relief, and thereby it can provide an slowdowning of the disease process. And they are only effective for younger patients. For me, the younger patients, in the sense, how young is your patient? Is it by the number? No, it is definitely not by the number. It is by the patient's physiological age. A 70-year-old who's still active playing a tennis is a physiologically young patient, according to me. So it is not that these agents are only effective for younger patients. They are beneficial for all the category of patients. However, what as a clinician we need to understand is, we need to assess the patient as an individual to understand his overall health status and how severity is that particular disease pathology. For example, a patient of 70 years with a grade 4 osteoarthritis, I'm not going to advise him to go on an orthobiologic treatment rather than go for a knee replacement as a definitive treatment for him. So it is a case-based decision, and it is based on the individual own disease-based decision and the severity of the disease. And is it the way it is said that it will replace surgery or any other treatment modalities? What we need to understand is, it can help to delay the disease progress, but it cannot completely stop the disease progress or reduce the need for surgery. And it is not always a substitute for surgery, especially in severe cases. So as I say, the patients who are presenting with a disabling advanced OA will definitely clearly benefit from a knee replacement rather than getting a multiple injections. So all orthobiologic treatment are the same. Is it so? No. You should understand that each agent is unique. Each agent has its own biological properties and way of acting, and it is specific for certain diseases at certain stages of the disease, and each works differently. So the indication of the choice has to be chosen before it is given for a particular patient. For example, PRP or hyaluronic acid combination has shown to be a good treatment modality for early osteoarthritis. Thereby, it buys some time for preventing the progression of the disease, and it also helps to continue the conservative treatment such as physiotherapy and other lifestyle modification changes needed for this. And orthobiologics are risk-free because it is taken from your own body. It's your own stem cell. Is it true? No, like any other treatment method, this also have its own side effects and complications. If you can see a PRP injection, which is given to a patient, it was given to a patient of both knees. However, one knee developed a reactive transient acute synovitis, which eventually needed an arthroscopic debridement of synovectomy followed by a course of antibiotics. So it can itself sometimes have its own side effects for the own patients, which has to be identified early and treated accordingly. And the patient has to be advised about the complications and the benefits which they will be getting out of these kind of treatments in hand, and taken the consent necessary. If you are not assessing properly and not giving the right injection without the sterility protocols, there are even chances that the patient may catastrophically end up damaging his knee in the form of septic arthritis. So these can regrow cartilage completely is another marketing trend which is being seen recently. Is it so? These can help actually to repair or regenerate tissue only to some extent. For example, a focal cartilage defect or an osteochondral defect can have a better clinical outcomes compared to an extensive degenerative disease where you cannot help to grow it completely. So the factor for successful orthobiological therapy include selecting the right patient and giving the appropriate dose. The treatment of underlying mechanical problem has to be addressed, and also depends on the age of the patient, the severity of the patient, and the cost effectiveness of the treatment. The results of orthobiologic treatment are permanent. Is it so? Definitely not. The benefits can be long lasting and depends on each individual, and it is not necessarily a permanent. So hence follow-up visits of the patients are needed, and if needed, an additional intervention will be necessary in the near future. So the longevity of the stem cell study injection therapy at 2022 based study says none of the participants opted for a surgical intervention after a 5-year follow-up of following a mesenchymal stem cell. But that is for a period of 5 years. Maybe over a period of 10 years or 20 years down the lane, the disease will have its own course of and he or she may need an additional treatment in the form of knee replacement or so. More injection mean better results. You cannot keep giving multiple injections, 10, 20, and say that you will be prolonged, you will be not needing a surgery at all. What we should understand is the effectiveness doesn't necessarily increase with increasing number of injections. And maybe 1 or 2 injections has to be determined based on case-to-base studies. And single injection itself study, there are enough evidence to show that single injection with good quality preparation can buy you a joint functionality for up to 6 months. And for advanced diseases, there is no evidence that even with multiple injections, you will be able to have a better results. So the take-home message with this kind of orthobiological treatment is always assess the patient preoperatively, a good clinical diagnosis, and then necessarily you have to think whether this patient, he or she is really going to benefit from the injection modalities, because it is mostly as an adjuvant treatment for the pre-existing rehabilitation for a conservatively managed patient, such as an early osteoarthritis in stage 1 and stage 2, or in a delayed or advanced cases where you give it as an additional option to buy some time. Or for example, a patient with a debilitated disease who he or she cannot buy advanced treatment, then in that stage, you can give as an adjuvant or a supportive treatment. So it has to be based on your patient own database, patient own base, and then you have to really consider whether they will really benefit from this treatment, and understand this treatment also has its own complications, which has to be explained and detailed and taken consent before you provide giving such modality of treatment. Thank you.
Thank you so much, ma'am, for such precise, informative lecture. Arindam sir, do you want to comment something?
So what percentage of patients, Samu, would you use orthobiological treatment? I mean, 1 in 100, 1 in 50? What kind of, or maybe more? What is your experience?
In my practice, less than 20% of my patients goes for this kind of orthobiologic treatment. Most of the patients actually benefit from conservative modalities such as physiotherapy and rehabilitation. And only I use this as an adjuvant treatment for buying some time and for non-responsive cases of osteoarthritis.
Okay, thank you.
Thank you so much, ma'am.
Thank you.
So,
Okay.
sir, can we begin?
Yes, can you see my screen properly?
Yes, sir. Your screen is perfectly visible, sir.
Okay, great. So
Okay.
we've discussed various modalities of treatment of knee pain, and now we are coming to.
Sir, very sorry to interrupt you, sir. So may I introduce you?
Yeah, sure. Go ahead.
Okay. Thank you so much, sir. So now I take this precious opportunity to introduce our fourth speaker, Dr. Arindam Banerjee, sir. Dr. Banerjee is highly esteemed consultant orthopedic surgeon at Narayana Health. He holds an MBBS, FRCS, and MSc in orthopedics from London and a diploma in orthopedic traumatology from Vienna. In addition to his clinical practice, Dr. Banerjee is the founder and medical director of Medline Nursing Home. He has special subspecialty interest in orthopedic surgery, particularly in acute trauma, including polytrauma and hip knee arthroplasty. He's also an examiner for the SICOT, a peer reviewer, and a regular faculty member. Furthermore, he serves as the president of WOC. So today, Dr. Banerjee sir will be discussing knee joint replacement. Who are the candidates? So without any further delay, sir, please proceed with your talk, sir. Over to you.
Okay, thank you everyone. And now we are going to talk about choosing the ideal candidate for TKR and also who should not be chosen. Now, the thing is that nowadays a lot of people do high volume or knee replacements. And I think in this hyped up corporate atmosphere and when there's a lot of marketing going on, we need to look at the science part, that who should we be operating on and who should we not operate on. So with this, we should think about approaching each patient with the idea of solving a problem and to try and achieve a goal, not for selling any product or any service. So we are not just technicians here who can do knee replacements, but we are doctors who have the best interest of the patient in mind. Now, there are specific features of a total knee replacement, and I'm going to discuss them. Now, I'm not going to go into unnecessary technical details because we are actually speaking to a group of doctors who are non-orthopedic surgeons, so there's no point in going into too much detail. But what we're going to do is try and define the problem and look at it holistically. Now, the knee replacement is a surface replacement where we remove the arthritic surfaces. This is quite different in concept from a standard total hip replacement where the entire joint may be removed, especially the femoral side, and an intramedullary implant is used, and sometimes a surface replacement is done on the acetabular sides. So it's important to understand that this is a surface replacement in most cases, though in complex TKRs, you may have to do an intramedullary component such as some kind of a femoral or a tibial stem. And below here, you can see the pictures here. Articular surface has been removed and replaced with a surface implant. In complex knees, however, you might have to do more complicated, might have to place more complicated implants, especially those with intramedullary components. The commonest cause for a total knee replacement is osteoarthritis, but it's also important to remember that it is also done for rheumatoid arthritis, occasionally for ankylosing spondylitis, secondary osteoarthritis, secondary to maybe a disease or due to trauma or any other condition where the articular cartilage is destroyed. And Of all these scenarios, the prognosis of a primary osteoarthritis is the best. So if you do a TKR for a primary OA, you get the best result. Now, the management of osteoarthritis has four main goals. One is control of pain and swelling. This is the most important one. Control of pain is what we are aiming at. But apart from that, we are also minimizing disability. We are optimizing the quality of life. And we are trying to prevent and delay complications which are associated with osteoarthritis. Now, these, as have been discussed in the previous lecture, there can be conservative things you can try, but there is a point at which conservative treatment fails, and then you have to consider surgery. But it's like a step ladder pattern. So you initially, when the patient starts with the problem, you can do some patient education, lifestyle issues, improve with physical and occupational therapy, weight reduction, exercise, maybe a stick, orthosis, medications, etc. But the problem is that there is often poor patient compliance. Initially, when the symptoms are not too much, then subsequently paracetamol can be given, NSAIDs like ibuprofen or diclofenac, aceclofenac. You can use topical NSAIDs, which also work. Problem with the oral NSAIDs is that they might cause GI problems. They have some CV risks. Occasionally, there are renal issues and hepatotoxicity. Now, further down, you can use other medications, other NSAIDs, coxibs, etc. Same problem. And then there is, of course, there is arthroscopy, which can buy you some time, orthobiologics, which have been discussed. But there comes a point when TKR is inevitable, or sometimes we start considering it. And though it is a major and costly procedure, it has to be done for advanced cases. And this is where we have to decide whether a patient is suitable for TKR or not. The treatment of osteoarthritis, therefore, includes the use of both conservative and surgical methods. You can use pharmacological agents or non-pharmacological agents. And you finally, when things are not working, then we will have to consider surgery. So surgery, we have to understand, is the failure of medicine. Now, which patients require TKR? Now, this is not an exhaustive list, but I'm going to harp on the major issues. The first is that the patient should be reasonably elderly. So we look at an age of 65, though in select cases, I think we can consider 50 or 55 in India. But normally we would like to do, the ideal patient has to be 65. The patient should have severe and chronic knee pain of moderate or long duration. So someone who's had knee pain for 3 days and comes to you should not be immediately considered for TKR. I mean, there could be some other pathology going on, maybe a high uric acid, or there could be infection or something like that. So this is one group, pain. Pain is the most important thing. Next one is severe deformity. So if you see someone with a very varus knee, a terrible valgus knee, and even if their pain is less, you have to consider doing a TKR. Then there's a group of patients who cannot do their normal activities, the ADL, which is the activities of daily living. So before you decide that you want to do a TKR for this condition, make sure that the knee is the culprit. Make sure that the pain is not coming from the back or from the hip or some other structure, which will not improve if you do a TKR. So one of the ways you can do this is to put some local anesthetic into the knee joint or give a knee block and see if it restores function. Now, sometimes we have to do TKR in cases where the joint is severely disorganized, badly damaged, such as in post-TB or rheumatoid arthritis. And there is another group who can function with NSAIDs, but remember, regular NSAIDs have a considerable morbidity, and therefore we should not allow the patient to take NSAIDs year after year after year. So we have to find another solution, and one of those solutions may be TKR, but there are other solutions like DMRD and biological treatment nowadays for specific conditions. I'm going to show you a very short video of what is being done. So you can see here that the femur is being cut in, there are 5 cuts in the femur and basically 1 cut in the tibia. So then you have the tibial base plate put on, and then you have the polyethylene put on, and the femur also gets a prosthesis. And then the patella, some people replace it and some people don't. I don't replace my patellas, but there is an indication for patella replacement in some cases. So, so basically, this is what is done. And then you have a result something like this. So you have a femoral implant like this and a tibial implant, and sometimes you have a patellar implant and sometimes you don't, depending on what kind of a knee you've done. Now, I've explained in one of the other pictures that this is the type of knee we do very commonly in primary OA, but there are some special cases when you might have to use different designs. And this is roughly what it looks like intraoperatively. So you can see here the base plate of the tibia with the polyethylene, and on top of it, you can see the femoral component of the prosthesis and the patellar component. Now, whenever there is a list of indications, there's always a list of contraindications. So again, this is a non-exhaustive list. I have listed quite a few. The absolute infection, the absolute contraindication is active infection. So if you have a patient with pus in the knee or very high CRP from infection, you definitely should not replace that knee. Similarly, there are a group of patients who have a lot of medical issues, cardiac problems, where they have a very low LVEF in the echocardiogram, or they have really bad kidney issues or lung issues, and they have severe comorbidities, and the patient is at high risk for life. So you need to really check if the patient is able to survive the surgery. Remember, this is not an emergency surgery like a hip surgery. So you have to think whether there is another option you can take for the patient. Similarly, there is another group of patients with neurological problems such as Charcot's joint, or people with severe muscle problems who cannot control the knee. Again, they are very bad candidates for a TKR because that TKR possibly may not work. There are some relative contraindications like intercurrent infections like UTI. I remember I had a patient like this who had a TKR on one side and was begging for a TKR on the other side, but we did not do it because we were unable to cure her of the UTI, and eventually she actually developed septic arthritis. So this is a sort of a patient you should be very careful before operating on. There are some neurological problems, problems with balance, with higher function. If the patient if there is a problem with higher function, again, you should think about whether you should do a TKR because they may not be able to control their knee very well. Skin problems like psoriasis of the knee need to be treated comprehensively. Otherwise, when you put your incision, you might get infection inside. So you have to be very careful. Previous knee surgeries. In these cases, some vascular complications are possible. For instance, if you have an incision which has been done, a transverse incision, and then you do a longitudinal incision, then you might get problems in the joint line. You have to be a bit careful about these things. I mean, these are not complete. I've done them several times, but you have to be a little bit more vigilant with your incision. If the patient has very bad circulation, arterial, if you see that the Doppler is not good, there's not a very good runoff in the vascular supply, or there's been a recurrent DVT, again, you have to be a little bit worried before you do a TKR. And also, before doing a TKR, a surgeon must be convinced on the basis of all this that the TKR is truly necessary, that other less invasive methods have been tried and have failed, and the patient is fit for surgery. And here, another thing, I think, especially in the Indian context, we have to think this through, that while Nowadays, people have come through various schemes and various government initiatives. There are large number of patients who pay for their own surgery, and therefore you have to make sure that they can afford the surgery, and especially if there is a problem or there is a lingering of the problem or there's a perioperative post-operative complication or the patient has to go to ITU, you have to make sure that they do have the funds to be able to afford treatment. Otherwise, the surgeon himself or herself will land in soup. Another important factor is that the patient should have home support, because if you do say a knee replacement in a person who lives on the road, then I'm sure you are looking for trouble. And similarly, you have to be very sure that the patient and the party are reliable and will follow your instructions and that they have a good compliance factor. The surgeon doing a TKR should also ensure that he has evaluated the specific problems of the patient, that he's operating on a patient who might have various types of complexities such as a severe varus, valgus, stiff knee. Long time patient may have been bedridden for a very long time with its associated complications. There may be a high fixed flexion deformity. Now the surgeon must be very sure that he has the necessary skills to handle this patient, and if he feels a little bit unsure, then he should definitely get sufficient help from the from his colleagues. He should also make sure all necessary equipment is available for that particular case, such as screws, extenders, wedges. Screws are particularly important in case there is, while doing the saw cuts, you end up with a piece of fracture or something like that. You must be able to manage it on the table and not leave it for another day. Similarly, be sure that your center can handle this patient medically, that you have the sufficient support of your medical colleagues, or if the patient has high diabetes, which is a very common thing in India. And can your anesthetist handle the patient? Do they have the requisite ICU backup? Now, patients will ask you a lot of questions, and these are the questions you should be prepared to handle. And for people who are referring patients to orthopedic surgeons, I'm sure that patients will also ask you in your clinic the same questions. So you need to answer these questions. So you have to think about them. The questions are: will this surgery hurt? How many days do I have? Do I have to stay in the hospital? Will I be able to get back to my normal activities like before, or whatever I could do? When can I leave the house? When can I climb the stairs? And how much will it cost? In these cases, I think you have to be truthful and promise in moderation. I don't think you should promise too much. You should tell them exactly what problems they are and how you plan to deal with it. But you should be in the situation. If you find yourself that you're not sure, then you have to be very realistic about the patient's condition and also about the capacity of yourself and your center. Now, counseling plays a very important part in choosing the right candidate of a TKR. So when you are talking to patients, again, this is the Indian context, and a lot of patients will have relatives who will come and talk to you. Make sure you're talking to the same group of people every day. Preferably, these are patients these are close relatives, and some of them may be paying for the operation. So you make sure that you know the relationship of the patient with the people you are talking with. Otherwise, you might find you're talking to someone who is really not involved and your counseling was in vain. You should give these people specific dates and times to talk to you. So you should tell them, look, I'm available on Tuesday at this time. This is my clinic. And you should write it down or make sure they make a note of it. Don't let them wander around the hospital searching for you, because they will go around and talk to all sorts of people, maybe the plumber or the electrician, and they'll get very funny messages. So you have to be careful about these things and give them a phone number of a senior assistant. So it's not possible that as a busy surgeon you can handle all their calls. So you can give it to a phone number to either your resident who is around, but sometimes residents have different shifts. So it's good to give it to someone like a senior assistant, maybe not even a doctor, but someone who is sensible. Now, the other thing is that you should make yourself very accessible to patients, but don't overdo it. Don't give your private phone number to everyone. because they'll be calling you at odd times, and you might be doing something else. You might be operating, and you might just not be able to handle it, or you might not be able to give a proper answer. So whatever you do, there are two things. You should avoid being rude to them, because this always backfires. You can scold them mildly, but never ever be vicious. And the other thing is, if you're taking a phone call, never shout on the phone. If you're doing something else or you get irritated, it's better not to take a call. That's why I said you should always give your number to a senior assistant. Now, you should have a plan. Once you've done the surgery is part of the treatment. Have a plan, and you should share it with your patients in writing. Now, I always make a plan after. So what I do is, once I finish my surgery, I ask the patient party to come to my clinic in the evening, and I write down my plan. So I write down date of surgery, date of dressings 1 and 2, dressing number 3 if it is required. Sometimes 2 dressings are sufficient. I write down the date of the removal of sutures. I write down the name and phone number of the dresser. Normally, I send a senior assistant to do all these things. It's not possible for me to be there all the time. I give the name and the phone number of the physiotherapist. So if it's a hospital patient, you usually make arrangements for hospital physiotherapy, and if they're going home, you try to arrange someone to do it at home. But if you're sending them from your private clinic, again, you should give the details of your physiotherapist. You should mark out the date of the next visit and who to contact in an emergency. So another thing, when they're asking you specifically, don't give dates, give a range. So don't say that when will I be able to go out. Okay, I would not suggest you can go out on 15. Don't go for that. Say that you maybe around 4 to 6 weeks. So use this sort of range when you're talking to them about the day the patient will be pain-free, the knee flexion, when you'll achieve 90 degrees, when you'll achieve 110 degrees. So give yourself a little space and time. And then, of course, you have to give them an idea when they can get back to work if they're working. But remember, a lot of these patients are elderly, so they may be retired, and there may not be so much pressure. But if you're operating on a 55-year-old and they're working, then definitely you will have to talk to them. Another important thing we have to realize when we are choosing the ideal candidate is that don't allow the patient to dictate the schedule. Okay, nowadays, again, you see a lot of patients who will tell you what they want. Like they will say, doctor, after the surgery, I'm going to fly to USA and be with my daughter in New York. I don't think that is a good idea. They will definitely have problems. I mean, if they travel abroad very quickly or they go somewhere else. So you have to tell them that what you think, and you should not, if they say, but I don't have time, I have only 2 weeks and I need to get this surgery done, and then I have to go XYZ. I suggest you don't do the surgery. You tell them, okay, you finish all your work and then we keep a healthy amount of time while doing the operation. You yourself should decide, take all these decisions and not be led by patient demand. Now, the other thing is, on this note, I think this is becoming increasingly important today. Having worked in this specialty now 35 years, I think I'm compelled to say this, that if you're dealing with patients who are foolish or over smart, then be very careful. First thing is, if you feel you don't need to do the surgery, try to avoid them. But then if you find that you can't, you have to do the surgery. Maybe there's a, someone important has asked you, you have to do the surgery. Then you just make sure that you've explained everything to the party in the presence of a person who is sensible, and you have a witness from the senior administration to listen. If you are very concerned, all corporate hospitals now have documentation, and you sign everything, keep a copy. And if you are really, really concerned, do an audio-visual documentation. I haven't had to do this yet, but I do know that my junior colleagues have already started doing this in high-risk cases. Now, you should always remember one thing very clearly. You have to do the surgery very well. Do your surgery well. There's no compromise on this. No amount of counseling can compensate for poor surgery or poor results. So if you've done a surgery, you've had a very bad infection straight away, or some kind of alignment problem. I mean, no amount of surgery is going to be able to compensate for that. But what good counseling does is that it converts average surgery into great surgery. So you've done a standard job and your patient is very happy. Or the other way around, if you haven't explained things properly, then even having done above average surgery, the patient thinks that there's some problem, or not, patient is not very satisfied. And I've seen this time and again in my career. So that's why I'm stressing this point without going into, for a primarily audience of non-orthopedic surgeons who are not involved too much in the technicalities. When you are referring patients, when you're talking to patients, it's very important to explain things properly. Now, again, another thing, based on the physiological fitness of the patient, you have to understand their expectations. So you have basically high expectation patients and you have low expectation patients. So patients who are the active type, who look at TKR in their health and look forward to continuing sports and travel, as well as going on with their careers, they are high expectation patients. So you need to select them carefully. You need to make sure they get their range of movement, or post-operatively. This will mean a lot of exercise, a lot of systematic physiotherapy, and these are candidates where you might have to think of other options, perhaps unicondylar knee, or maybe if you're doing a hip surgery, maybe a surface arthroplasty. But even if you're doing a normal TKR, you should again make sure that the rehab is perfect, and we'll have a lecture on rehab right after this talk, so you can listen to this. They need, since they are mostly fit patients, they need less monitoring postoperatively, but they need more rehabilitation. The low expectation patients, sorry for the typo, these patients are having the operation for severe pain, deformity, and disability. So you make sure that you counsel them appropriately. But one thing I have learned in my career, do not overexercise them. They cannot handle it. So patients who are primarily sedentary, who have not exercised for 30 or 40 years, if you suddenly start exercising them a lot, they will have pain, swelling, bleeding, and lots of effusion. So I would not advise it. Just make sure they do physiotherapy regularly. Go with small goals, but build it up. These are the patients who have multiple comorbidities, various types of medical issues. So they need much more post-operative care. But once you have got them over the post-operative care and you send them home, they are easier to handle, and they are usually very satisfied with the surgery because they have lower expectations. So my take-home message is, make sure you do proper patient selection. Make sure you know your patient profile properly. Now, I've used the term KYP. The banks, they profile us nowadays, they say KYC, but we need to know our patients' KYP. We should counsel them in a language that the patient can understand. By this, I don't mean counsel in English or Hindi or your vernacular. What I'm trying to say is that make sure they understand. And one of the tricks I've learned is that after explaining something, I ask them, what did you understand from what I said? And I've often found, at least in 50% cases, that they've understood the exact opposite of what I conveyed to them. So make sure they've understood the message, and try to talk to the same group of people. If you're in doubt, document, and whatever you do, be very cool and never shout at people. Thank you very much.
So, yeah, originally the topic of my talk is rehabilitation of the knee joint, with a motto, with the idea of reading between the lines. But while thinking of reading between the lines, in this 12-minute slot, I thought that rehabilitation of knee joint is too broad spectrum and too non-specific. So I made it a little specific by picking up the one single entity, the commonest knee pathologies, that is knee osteoarthritis. But in principle, it will be same, because we are going to find out we are trying to read between the lines. So a little bit of change topic is the rehabilitation of ONE, reading between the lines. But now, if we want to read between the lines, we should concentrate, I think, on the etiopathogenesis of osteoarthritis. The three most joints to be involved in osteoarthritis are knee, hip, and first CMC. And now if we look at the evolutionary morphology, we can well understand that these three joints underwent extensive changes, transformation. The first two because of our upright posture and bipedal gait, and the last one because of our prehensile grip. So to climb to the top of the evolutionary tree, we had to pay some price, and that is in terms of susceptibility to osteoarthritis. Again, it has been seen in various studies that intra-joint damage takes place in the area of maximal loading. So evidences are there that there is no doubt that osteoarthritis is a biomechanically driven disease. But at the same time, it has also been found in various studies that adaptation to altered joint mechanics leads to a certain stage where chondrocytes become extremely active and the bone turnover gets increased, especially in the early phases of osteoarthritis through the mediation of cytokine signals, increased matrix synthesis, local inflammation, enzymatic breakdown, etc., etc. So evidences are again there to believe that osteoarthritis is biochemically mediated also. So in a nutshell, we can say that osteoarthritis is biomechanically driven but biochemically mediated disease. Again, lots of ample evidences are there to believe, to know that mechanical stress leads to altered metabolism and release of interleukin-1, TNF-alpha, MMPs, NO, and PGs. Uniaxial unconfined dynamic compression upregulates COMP expression. Mechanically induced release of chondroprotective cytokine interleukin-4 is deficient in osteoarthritis, and abnormal mechanoelectrical stimuli result into abnormal ECM remodeling and function of chondrocytes. So the mechanical forces, I repeat, the mechanical forces induces this inflammatory and biochemical cascades leading to osteoarthritis. This diagram has been taken from famous textbook of Kelly's textbook of rheumatology. So the biomechanical factors play central role in pathogenesis of
Dr. Das,
osteoarthritis.
we
Yes,
cannot
please.
see your, sorry, we cannot see your slides. I think.
Really? But
I think you have
okay.
shared. Yeah, just share your slides.
I have shared it anyway. Is it visible now?
Yes, yes, yes.
Is it visible?
Yes.
Clearly, okay. So this was my first slide.
Okay.
I was talking about the joints most commonly affected in osteoarthritis, knee, hip, and first CMC. Then I proceeded to this one where it was shown that in early osteoarthritis, these things happen, and it is also biochemically mediated. And I was talking about these where it was substantiated with these evidences and also with this diagram that mechanical forces or the biomechanical factors play a central role in pathogenesis. So I'm moving to our next slide. So though the changes in the articular cartilage are the most critical, we often measure the joint narrowing or the JSNR, joint space narrowing, by indirectly measuring the cartilage thickness. But we should remember that OA involves the bone, synovium, joint capsule, other intra-articular and peri-articular structures, and often the primary pathology lies in the structure. So we should keep in our mind that osteoarthritis is not merely synonymous with cartilage destruction. These I have already discussed, the biomechanical factors, the importance of biomechanics in pathogenesis of osteoarthritis knee. And it has been found that in a biomechanically normal joint, the non-injurious loading result into normal cartilage mechanobiology, whereas the same non-injurious loading in a biomechanically abnormal joint results into cartilage damage or osteoarthritis. So the cartilage is not the culprit, but a victim in many cases. So we must remember when we'll formulate the rehabilitation, when we'll prescribe the rehabilitation, we should remember these two factors, that the biomechanics is the primary thing behind the etiopathogenesis of osteoarthritis, and primary pathology may lie in other structures. So we should not formulate our rehabilitation in a chondrocentric or cartilage-centric manner. Rather, we should address the joint as a whole. And now coming to the TKR, we have learned enough, but I am thinking of my aspect. The principal aim of TKR, the TKR is the only definitive treatment of osteoarthritis, definitely the severe grades. The principal aim is there, restoration of painless movements of the knee joint, and that is achieved by restoration of the functional anatomy, restoration of the alignment, restoration of the soft tissue balance, restoration of the joint line. That means restoration of the joint biomechanics. So biomechanics of the knee and its restoration are key to improving both function and survival of any knee patients before and after TKR, with or without TKR. Now these are there are different guidelines for osteoarthritis. I'm just skipping the slides. I'm not going into details of these. There are many more also, but in most of them, the structured exercise come first, because that is going to alter the altered biomechanics in a positive or favorable manner. So whether we use DMOA, the disease-modifying osteoarthritis drugs, or orthobiologics, unless and until we give enough importance on restoration of altered biomechanics, nothing is going to be successful, because in the etiopathogenesis of osteoarthritis, the biomechanics, biochemistry, and biophysics all converge into one single point. So again, this evidence, I'm not going into details of that. And this is the Italian multi-disciplinary consensus guideline. I'm also skipping this slide. I'm going to some other important thing. I was talking about other tissues. So if we need to concentrate on one particular structures, we need to concentrate on periarticular muscles. And the early 70s, 80s, the investigation, the research was started, but at the beginning of 1990s, it was substantiated by many good, studies that the primary pathology often lies in the periarticular muscles. And I have just mentioned here two such studies at the early days, 1991 and 1990. There one was showing that quadriceps weakness. This was the first reported case which showed that quadriceps weakness is a risk factor for incident radiographic OA knee. And another study, it showed that muscle weakness leads to micro-incoordination, leading to cumulative joint damage, leading to primary osteoarthritis. And think about that. These periarticular muscles acts as the dynamic stabilizers. They negatively, actively absorb the shock and reduce the load on joint, thereby diminishing the joint damage. They do this negative work through the eccentric contraction. Think about when someone is jumping from a height on a ground. Initially, he or she lands with flexed ankle, flexed knee, and flexed hip. Then gradually it gets extended, slowly and gradually. through the anti-gravity actions, through the eccentric muscles of the antagonistic muscles. And by doing so, they reduce the load on the joint. Forget about jumping from a height. Think about a slow-paced walk, gentle walk. The dynamic forces in slow-paced walk, gentle walk, the compressive force is 6 times the body weight, and shear is 2 times the body weight. So the resultant force is 7 times body weight. And think about average 1,900,000 steps per year. So what can be the cumulative damage on the bones, on the cartilage, on other structures? But these are definitely guarded by the periarticular muscles. Believe it or not, the energy produced by normal walking just to make one single step, one single foot forward is enough to shatter all the ligaments, all the static stabilizers of the knee. So the static stabilizers are important. We give enough importance on static stabilizers. We give non-surgical and surgical treatment when the static stabilizers are torn or injured. But at the same time, we should much more importance on the health of the periarticular muscles. And as I was talking about, this diagram shows that how quadriceps weakness through anterior-posterior instability, decreased muscle recruitment, and resultant braking actions, less muscle incoordination can all leads to osteoarthritis knee. And this initiates a vicious cycle. Way knee to pain to disuse to quadriceps weakness to knee way. Again, the same thing repeats. So this vicious cycle has to be broken, and only if we give enough importance on the periarticular muscles with the aim to restore the biomechanics of the knee joint, then it can be possible. So these are some specific rehabilitation measure targeting the joint as a whole, or maybe some individual structures at one time. So when we target the joint as a whole, weight reduction is a good measure. Gait training shock absorbing shoe is another thing which can reduce the joint reaction force, which can rather redistribute the joint reaction force in a more favorable way. Talking about the muscle and tendon, the strengthening exercises are the most important thing of this rehabilitation protocol. The strengthening exercises should be, is again divided into isometric and isotonic, and isokinetic exercises is not that much of favored except some cases used in the sports medicine. So isometric exercises, wherever possible, should be done in a multiple angle manner, because the increase in strength of the muscle is particularly done within 10 degrees of the particular angle where this isometric exercise is done. And that is the reason, wherever possible, multiple angle exercise should be done. And in case of knee, multiple angle isometric exercise is the rule, so that the muscle is getting strengthened throughout the range of motion. Otherwise, our work is not even half done. And then comes isotonic exercise. This can be OKC or CKC. All of us know this, but we should not stress on concentric contraction only. We should equally concentrate on eccentric contraction. Otherwise, the coupling, the co-contraction, the proper coordination of the agonistic and antagonistic muscle cannot be achieved through the concentric and eccentric contraction. And that is the reason we should concentrate on this. Now, coming to the proprioceptive nerve, yes, the proprioceptive input enhancement exercise can also be given. And in some studies, it has been seen that proprioceptive nerve neuropathy is the initial cause of the osteoarthritis, and this is more so in Charcot's joint. Coming to the ligaments, orthosis can supplement something from external, give some support, but again, the eccentric muscle strengthening exercise has much more important role to play. And coming to the joint alignment, the wedged insole and heel wedge, it has query efficacy. The level of evidence is not very strong, but orthosis, especially the medial and lateral offloading or the varus correction or valgus correction orthosis, has some role, definite role. It has been evidences are there. And especially in my clinical practice, those high-grade osteoarthritis, grade 3 or Kellgren-Lawrence grade 3 or grade 4 osteoarthritis with severe pain, with severe varus or valgus, for whom the TKR is contraindicated, or any other surgery, varus correction surgery is also contraindicated. And on those few patients who don't want to go for surgery, I have got good results in them. And while we target the bone and cartilage as a whole, the moderate impact loading exercise is very good for them. Because the slow loading, in case of slow loading, that there is enough time for fluid redistribution, and that leads to decreased force applied to the matrix framework. But in case of fast loading, the insufficient time is there for fluid distribution, which results into increased stress on the matrix. And that is the reason why the repetitive low impact loading is favored, because the repetitive low impact loading induces good mechanobiological response, and they not only reduce the cellular damage, but also they promote cellular healing. So walking not only reduces cartilage damage, but at the same time, walking, especially in the early stages of osteoarthritis knee, can actually heal the cartilage. And there are some good studies to substantiate this. But the running, jogging, which is high impact loading, that is not good for osteoarthritis knee. So we should rather remember 3 or 4 things. If we try to read between the lines regarding rehabilitation of osteoarthritis knee, number 1 is that biomechanics play the central role. So we should try to restore the altered biomechanics. Number 2, the primary pathology may lie in many structures apart from cartilage. So we should not try to do in a very chondrocentric manner using only disease-modifying osteoarthritis drug or only using orthobiologics. Rather, we should target the joint as a whole in a comprehensive manner, in a complete manner. And number 3, the most important structures for restoration of joint biomechanics or near normalization of joint biomechanics is the periarticular muscles. Thank you very much.
Thank you, Dr. Das. One question. I think
Sure.
since you were referring to muscle problems, I think sarcopenia, there's
Yeah.
been a thought that if you take some essential amino acids, now some companies are promoting this, that this will help. Do you think this taking essential amino acids has a role?
Yeah, taking essential amino acid has definite some role, because actually the balanced protein diet is needed for the muscle health, as you know. So in that case, if the essential amino acid is deficient, in that case, it is going to help. But otherwise, if it is surplus, then it may not work. But at the same time, we should remember that if we take only amino acids or good balanced protein, that only not going to help in sarcopenic cases, because we need to do some strengthening exercises also. And these strengthening exercises, previously there was a thought, rather in these days also, there is a myth that a strengthening exercise is for the young individuals only, or strengthening exercises maybe on a particular sex, particular gender. But now there is no doubt that strengthening exercises is for all. So the coupling good quality protein diet along with strengthening exercise will address the problem of sarcopenia.
Okay, great. So I think there are 7 questions here. Lucia, can you?
Yes, yes, absolutely. So thank you so much, all the doctors, for your wonderful presentation and deliberations. It was, I believe, informative. Therefore, we have got a couple of queries from the participating delegates. So with all of your permission, we would like to present those questions, and I would like to request the speaker, if you can close the screen sharing from your end, sir. So it would be helpful so that I can share the screen again.
Didn't I stop it?
Yes, sir.
Is it okay?
Not yet, sir. Shall I do it from my end if you don't mind?
Yeah, I won't mind. Let's do
Okay,
it.
sir.
Okay, so this question I think was given to Chinmoy, but I think Chinmoy has left. So let me answer this. Chronic osteoarthritis pain not subsiding even after taking routine medicines after 1 month. Difficulty in weight bearing, what to do? Okay, so the thing is, we must understand that chronic osteoarthritis is, all cases of chronic osteomyelitis is not the same. So it can be a grade 1 and it can be a grade 4. Okay, so for all these different groups of osteoarthritis, the best way to assess them is to do a load-bearing X-ray. And once you see the X-ray, you should be able to get an idea about what is the level of problem you have. So if it's a fairly organized knee and there's just a little bit of early osteoarthritis, it should be possible through various lifestyle changes, as discussed here, that we, doing exercises, then doing physiotherapy, doing taking medicines, that should be sufficient. Now, if it is a little bit more than that, then of course there should be, paracetamol and then various types of NSAIDs should be taken as well, with kneecaps and some kind of a exercise program, etc. If it is more than that, then you can buy time with orthobiologics depending on the age of the patient. If the patient is middle-aged, then you can buy time with orthobiologics, various types of DMRDs in cases of inflammatory arthritis, or you can also do arthroscopic debridement, washouts, occasionally steroid injections. But beyond that, of course, I think you have to consider surgery. There are different types of surgery, starting from depending on the type of problem you have, whether you require a high tibial osteotomy, or you require a total knee replacement, or you need a unique condyle replacement. So you should see the level of chronic osteoarthritis before taking a decision. And usually it's based on X-rays, but occasionally a MRI might be required. Okay, so I think this is the answer to the question. So I think a proper patient assessment investigation should be done after, if medicines are not working, and a further decision needs to be taken. Okay, next question. Okay, so I think Samu, can you take this question, please?
Yes, sir. Medicine approaches be applied to optimize the use of orthobiologics in individual patient. I think I have clearly explained in my lecture that we need to choose the treatment of orthobiologics. Orthobiologics is a broad spectrum. It varies from the range of injectables, even medications, and most are in the clinical trials. Though the few which are most commonly used with evidence are PRP, hyaluronic acid injections, and VMAC injections. So it depends on, as I said, depends on the spectrum of patient and the age of the patient and the general overall well-being of the patient, in which category of the disease spectrum the patient is falling in. So possibly, if, for example, if a case of osteoarthritis I'm dealing with, I would like to use these as an adjuvant treatment modality. For example, in a stage 2 to 3 osteoarthritis, to help in the patient to work more towards the physiotherapy and rehabilitation as a source to alleviate pain and to buy some time to prolong the pathology of the disease. So this is this is a very broad question. So I think I have clearly explained that we need to customize it for each patient.
Thanks, Samu. Now, can you place the next question, Rupsha?
NSAIDs, anticoagulants.
Okay.
It's a very good question. The orthobiologic treatment interaction with pharmacological therapy such as NSAIDs, anticoagulants. Yes, if my patient is on chronic anticoagulants, I think I would, before injecting any injectables into the knee, the regular surgical precautions has to be taken. The particular anticoagulants has to be stopped because the possibility of hemarthrosis has to be considered. And it per se doesn't have any interaction with oral NSAIDs such as paracetamol or diclofenac, and it can be taken together along. But anticoagulants, because I'm not going to give it as an oral form of medicines. Most of these orthobiologics are injectable medicines, and mostly it is a single dose of injection. So the general surgical protocol has to be considered, outweighing the risk of anticoagulant for that patient. For example, he or she is a chronic patient, like an atrial fibrillation patient on anticoagulant, then we should really think about stopping the anticoagulant and giving the injection rather than going for a more conservative mode of treatment rather than giving the injection. So each, again, it is customized to each patient individually.
Good. Thank you, Samu, again. Next question, please. Okay. So I think I'll take this question. How do perioperative management strategies, including pain control, anticoagulation, infection prevention, contribute to improve surgical outcomes? So we need to be first sure what surgery are we doing. So are we doing arthroscopy? Are we doing some kind of a alignment operation like H2? Are we doing a TKR? So it's of course important. I mean, all these points are very important. So you need to, of course, give preoperative and postoperative pain control. If the patient is young, you can use things like NSAID, but if they are elderly, which they are often in cases of TKR, then you might need to do things about epidural injections. You might need to give knee block, you can give a femoral block. These are all the strategies I've used, or you can combine all these with pethidine stemetil in the postoperative period. Now, anticoagulation, nowadays you need to, think about DVT in all patients. So you need to give the standard protocol for anticoagulation. I use, in my practice, I use Clexane 40 milligrams. Okay, so that is a thing which we normally use, and we use it right after the surgery. But there are other various types of medications available. Some people even give low dose aspirin. The infection prevention, again, this is very important. In knee replacement surgery, for instance, you need to give antibiotics at induction while the patient is having anesthesia. And this needs to be repeated. I normally would give 3 doses of antibiotics IV. But if you think it's a high-risk patient, I think it's better to be safe than sorry. And you might consider giving them a course of 5 days antibiotics. It depends really on what you see as the profile of the patient. So some patients are, relatively risk-free, and you can get away with very little antibiotics. Other patients, you have to be very careful. Okay, next question. What are the current recommendations for use of multimodal analgesia and regional anesthesia techniques in knee joint replacement? Okay. So speaking from my own experience, the things which we do in our practice is that uh, we often do the either the operation is done under a spinal or in a epidural, or it could be combined. Now, post-operatively, if you're just doing a spinal and the spinal is wearing off, then the options which you should adopt, one of them is your anesthetist can give femoral block right after surgery. That's one of the options. The other option is that you have a sort of a cocktail which you can inject into the knee joint, and you have to be a little bit careful that you inject the anterior part of the knee, you inject the posterior part of the knee, being very careful not to go into the popliteal vessels, and you should inject all around, and you can put some medicine also um, in the the subcutaneous tissue under the skin. Now, apart from this, if you are doing an operation under epidural, then you can keep the epidural on. So, right, there are two ways you can do it. One is that you can maintain the epidural for 48 hours. And if you're doing that, I suggest that you try, unless you have a lot of residents who are following up the patient. If you have just one resident or two residents, then you have to be careful. You should place the patient in the ITU because often they have hypotension after giving regular, epidural anesthesia, and this, of course, should be done properly with gradually. The levels should be maintained with the. You have the machine. I just can't remember the name of it. You just make sure that that is given properly. The other option, of course, is that you can just, when the anesthesia is wearing off, the anesthetist can give a top up of the epidural and then take out the epidural, and then you have to combine it with pethidine, Stemetil, NSAID if the patient is young. But again, you have to remember that while you're giving all these medicines, especially pethidine, you have to be careful in some cases. Those who have a history of abdominal surgery or something like that, I have seen cases where you can end up with a subacute intestinal obstruction. So, I mean, there's no one way. You have to be, balanced. You have to know your patient very well, and you need to make sure that you practice very careful and safe analgesia. Okay, thank you. And next question, please. Okay, I think this is a question for Dr. Das. Dr. Das, rehabilitation. Dr. Das? Okay, I think Dr. Das is not here right now. Okay, Shashi, can you take this question? Dr. Das, okay, there you are. Yes, Dr. Das, can you take this question?
Interdisciplinary collaboration is very important in any kind of in knee rehabilitation outcome here, but it should be done among orthopedic surgeons, the physical and rehabilitation medicine specialist, physiatrist, and other healthcare professionals. Okay, so physical therapists are there in the other healthcare professionals category. So definitely a few other doctors like anesthesiologists, orthopedic surgeons, the pain procedure management specialist, the physical therapist, occupational therapist, orthotists, they will come under the other healthcare professional category. And also the rehab nurses, everybody should cooperate in a manner. And it's a continuous process. It's not just if a patient requires a surgery or if a patient doesn't require surgery. It is always a collaborative effect. And even if a patient requires a surgery, before surgery, at the time of surgery, and after surgery, again, it is a collaborative effect, and it's a team approach. The rehabilitation is a comprehensive thing, and it's a team approach, and lots of specialist doctors like orthopedic surgeon, like physiatrists or PMR specialists, like pain specialists are involved. And also, many of our patients, we are talking about osteoarthritis knee, many of our patients are of the elderly, and they are having the diabetes mellitus. They are having, say, problem of hypertension and some heart diseases. So the internist, internal medicine specialist, cardiologist, and all specialists are also part and parcel of this team effect. And definitely the other healthcare professionals' role, like physical therapist, occupational therapist, and orthotists, especially those who give them orthosis, different kind of orthosis, their role is also very important. So the communication is a key, and everybody should have a good, friendly attitude, and that everything should be communicated, and what is expected from a particular specialist or some other healthcare professional, that should be clearly mentioned, and that should be clearly known and clearly conveyed from and to. And that is the way how the rehabilitation outcome can be done very well, because as I am telling and I am stressing again on the fact that it's a multidisciplinary team effort, team effect. So for a proper outcome of the rehabilitation, the favorable outcome of the rehabilitation, this collaboration is highly needed.
Thank you, Dr. Das. And
Thank
any more? Any other questions? What future advancements or innovations in rehabilitation techniques and technologies could potentially transform knee joint rehabilitation? Okay, another question for Dr. Das.
Yeah, right now they're also thinking about the robotics, the rehabilitation of robotics. So that is a more precise, more accurate. So this in rehabilitation, robotic assisted rehabilitation can be a thing of future, not very far future. It's a recent future. Also, in many cases, in many centers, it has already been started, but the knee joint rehabilitation, it is not yet started in that commonly, but soon it will come. And the future advancement or innovations in rehabilitation also involves, we have spoken about orthobiologics, we have spoken about disease modifying osteoarthritis drug, but apart from that, we have also we were also talking about surgical and non-surgical approaches, but there are some minimally invasive procedures which doesn't utilize that orthobiologics, like radiofrequency ablation. In those cases, in very painful knees, and where either the surgery is contraindicated or the patient doesn't want to go for, I do personally, I do, and many other doctors do, the radiofrequency ablation of the genicular nerve. And so there are some other techniques which is coming also. So these are the few things which will come in the future. But I don't think that they have that much of capacity to potentially transform the knee joint rehabilitation, except the robotics assisted rehabilitation.
Okay, thank you, Dr. Das. Any more questions?
Welcome.
Okay, so
you.
I think that was a very interesting discussion. Before we ask CLIRNET to say, finish this topic, I will request Dr. Sasinder to wrap up this session with a quick summary and vote of thanks.
Yeah, thank you very much, Dr. Arindam. Thank you very much, Dr. Madhav Das, for a wonderful presentation. Thanks to CLIRNET and to WOC President for allowing this collaboration for this interesting and easy to understand program on approach to knee problems. I guess the variety or the spectrum of problems or the knowledge sharing has been done with this program, as in understanding the symptomatology, understanding what are the treatment options with focus on arthroscopy, identifying the right patients for knee replacement. especially with advanced conditions, and the rehabilitation perspective, the principles, what you should understand when you're trying to rehabilitate a patient. So I think this was a wonderful program, and the recording will also be available to watch later. Is that right, Mr. Rupsa? I guess it will be available in CLIRNET and also in our own YouTube channel. Thank you very much.
Ruksha, do you want to say anything?
Yes, sir.
CLIRNET? Yeah.
Yes, sir. Thank you so much, all the speakers or the doctors, for your wonderful presentation and the discussion. It was very much lucid and comprehensive as well. And therefore, we will like to call it a day. And before concluding, I would like to request all of you, if you have any further queries based on today's session or speaker's speciality, please do not hesitate to get back to us by following this social media platform so that we can have a discussion on your suggestions later on. So thank you so much, all of you, and the doctors too, and good night to all of you.
Okay, thank you everyone, and thank you for
Thank you
attending.
very much.
And from
Right.
the World Orthopedic Concern International and World Orthopedic India Concern, we are happy to have participated in this seminar. I'm sure we will do more in the future. Thank you again to everyone.
Thank you.